Good afternoon, everyone. Thank you all for being here. It's always tough on a beautiful day like this to be sitting in this room, so thank you for still sticking around. Again, a big thanks to the organizers, the chairs of the committee for inviting me here. And I think more than me, I think my family is thanking you because we left Minnesota when it was 7 degrees, and so that's almost a 75 to 80 degree difference here. And in fact, we had some snow last night, and I think when we get back home tomorrow, it's likely that I'm going to need to clean the driveway and the car before I can take it from the airport back home. So I'm going to try to enjoy this evening and tomorrow morning a little bit before I head back. So again, thank you for being here. My talk for today is on cardiovascular disorders. This is a pretty vast topic to cover in 1 hour. I'm going to try my best to condense the talk a little bit more. And in fact, if you look at your booklet, the number of slides are around, I think, 120. I cut it down even further for my talk here. So at least you have that as a reference if you need to go back and take a look at it. And if there are areas that I'm not covering, I'm happy to stay back and answer any questions that you might have related to that. Okay. No financial disclosures. So these are the areas that I'm planning to cover in the next 50 minutes or so. Talk about the cardiovascular homeostasis in normal sleep, talk about sleep duration and depth, and in terms of how it's related to cardiovascular disorder as well. Talk about obstructive sleep apnea and its consequences related to CV disorders, and then central sleep apnea. So I'll start off with the cardiovascular homeostasis. This is something that you may all know, and I'll give you a little bit of a rationale behind how the American Academy of Sleep Medicine came up with a definition of bradycardia while asleep. And as you can see out here, the definition is based on the heartbeat of less than 40 beats per minute while sleeping, and sinus tachycardia while asleep is going to be more than 90 beats per minute. And as you all know, this is different than the current definition. While you're awake, it's 60 beats for sinus bradycardia and more than 100 beats for sinus tachycardia. And I think you also know that this is all based on a single lead EKG or ECG that we have on our PSG fragment. And the reason why the heart rate tends to dip down while one is sleeping is because of predominant parasympathetic tone and a withdrawal of sympathetic at the same time. And I'll touch upon this a little bit more in terms of when does the parasympathetic predominance happen and when do we have more of a sympathetic surge that tends to occur during sleep. And the lowest heart rate, because of the parasympathetic predominance, tends to happen during non-REM sleep. And again, this should all be sinus bradycardia. Anything different than that may be actually abnormal. And this is based on the Sleep Heart Health study, where they looked at more than 2,000 patients, more so females than males, with a mean age, as you can see, around 62 years, with none of them being on any cardioactive medications and none of them having sleep disordered breathing. And when they looked at the minimum normative data with plus or minus 2 standard deviations, men had a heart rate of around 43 beats per minute, plus or minus 2, and women 47.5 beats per minute. And that's where the cutoff of 40 beats per minute came for sinus to be called as less than 40 beats per minute to be called as sinus bradycardia while one is sleeping. And for sinus tachycardia, of course, while you're awake, it's more than 100 beats per minute, even though some have advocated from the ACC, the American College of Cardiology, to have it even lower than the cutoff being at 90 beats per minute. But however, it still, I think, still stands at 100 beats per minute, while sinus tachycardia while asleep, per the scoring, is going to be more than 90 beats per minute. And this is, again, based on the Sleep Heart Health study, where the upper limit of normal was, as you can see, for men was around 80.8 beats per minute, and women was 84.7. And if you include the standard deviation, that's how the AASM came up with a cutoff of 90 beats per minute. And this is a hypnogram that you've seen for the last 2 days here, where the only reason I put this up out here is to illustrate that non-REM sleep occupies about 75% of the total sleep time in normal healthy adults, while REM occupies about 25%. And the reason for knowing that is because non-REM, there's a predominant parasympathetic tone. And at the same time, when you have increased parasympathetic tone, there's withdrawal of sympathetic tone at the same time as well. And so it's a quiescence period, actually, for the heart in terms of cardiovascular stability, and also along with it, you do have bradycardia too. And because blood pressure, by the way, is cardiac output times your systemic vascular resistance, and cardiac output is stroke volume times heart rate. So when your heart rate tends to drop, there is a drop in your cardiac output and a little bit drop in your systemic vascular resistance, and a combination of both leads to a drop in your blood pressure. And the reason why that's important is because we are all should be actually, hopefully, normal dippers, where while asleep, our mean arterial pressure, as you can see out here, while awake is a little high, but as you fall asleep, it should start dipping down. And this is the normal dipping phenomenon that we should all be having because of our increased parasympathetic tone that happens during 75% of our non-REM sleep. And when you don't have that, so when you have a little higher blood pressure while asleep compared to the normal dipping phenomenon, then that's abnormal. And they are called the non-dippers. The ones who don't dip are the non-dippers. And the reason why that's pretty important and significant is because it's implicated in various cardiovascular disorders. The risk for heart disease, including CVA, stroke, daytime hypertension, drug-resistant hypertension, where defined as more than 3 drugs to control blood pressure, congestive heart failure, and there's also increased, studies have showed increased risk of mortality in people who are non-dippers. So when you see this, where the first sign in some of these patients might be that the blood pressure is a little high during, at least compared to normal, even though it may not necessarily be high, even if you don't see the normal dip that tends to happen, that might be the first indicator that there could be an increased risk for cardiovascular events in the near future. This is a study from the Dutch study looking at certain outcome measures, and they looked at more than 5,000 patients. Here you can see on the x-axis you have the systolic and the diastolic blood pressure out here. And on the y-axis, you can see various factors that are being looked at. And this is just to show you that the strongest predictor for a 5-risk cardiovascular death was actually the nighttime blood pressure compared to 24-hour or daytime or even blood pressure that's measured in the clinic. So if you see that lack of normal dip at night in terms of your blood pressure, then that might be a big risk factor for subsequent cardiovascular issues. REM sleep, on the other hand, which occupies around 25% of our total sleep time, is a stage of complete autonomic instability. And the reason for that is because you have increased surges in sympathetic tone, and in fact, it's also interspersed with increased vagal tone that tends to happen, particularly during your tonic phase of REM sleep. So we have the tonic and phasic REM. So when you have phasic REM, with those eye twitches that tend to happen, you're more likely to have more sympathetic drive. The tonic phase might be a little bit more of your vagal tone that tends to predominate. And when you have usually between the transition between your phasic and tonic, or tonic to phasic, is where you might have an increased surge of vagal tone that can subsequently cause sinus pauses. And I'll just show you an example of that here in a second. And because of these sympathetic surges, you also tend to have variability of your heart rate, more so in the tachycardic than the bradycardic area, and also big changes in your breathing rhythm abnormalities, because the brainstem, which is where your cardiovascular circadian systems is also located, tends to lead to some apneic episodes, which we probably have all noticed during our PSG scoring, and that's all because of what tends to happen around the brainstem area. So this is a study that was done by Dr. Viren Somers. He's at Mayo Clinic, but this study was done when he was at University of Iowa, where he placed a microelectrode in the peroneal nerve of normal healthy subjects so that he could look to see what happens to the sympathetic discharges at the peroneal nerve area in these normal subjects. So while awake, as you can see, is listed out here. Oops, sorry. soon. Okay. So this is while awake here, and then this is of course 1995. We had stage in 1 and 2 and 3 and 4 and REM sleep, or sorry, stage 1, 2, 3 and 4 followed by REM sleep. And here, in each of those, you can see that there is blood pressure and heart rate, along with a channel, along with a column for sympathetic activity. And as you can see, as one goes from wakefulness to stage 2, 3, and 4, the sympathetic discharge activity decreases significantly and almost becomes nil in stage 4. While along with it, you see a drop in your heart rate and your blood pressure. While in REM sleep, you can see surges of sympathetic activity leading to fluctuations in your heart rate as well as in your blood pressure. And this is again a normal subject. And this is an illustrative example of what he ended up finding, because if you look at your heart rate and blood pressure, it tends to fall as you're falling asleep, particularly as you're getting into the deeper stages of sleep. And in REM sleep, you can see an increased surge in both your heart rate and blood pressure, and that seems to be predominantly related to an increased activity of sympathetic nervous system. And this is an example of Dr. Christian Guilleminault from Stanford, where he noticed at the transition from non-REM to REM, in a young, healthy 20-year-old, he saw a 9-second pause, enough to scare anyone probably, and particularly in this particular subject who was otherwise pretty healthy. And because anytime anything more than a 3-second pause, we call that as asystole, and a 9-second pause is something that could be seen in some healthy subjects, particularly even in normal healthy subjects, particularly if they have a robust autonomic nervous system activity. So this is just to summarize something that we've talked about so far, where when you have, particularly in REM sleep, when you have surges in blood pressure and heart rate related to increased sympathetic drive, along with maybe some underlying cardiac history to begin with, that then tends to lead to cardiac ischemia and arrhythmia. And this is one of the reasons why you tend to have subjects with underlying heart disease might be at an increased risk for sudden cardiac death, particularly during the morning hours. And I'll show you a slide in a second in the next few minutes here. So changing gears, let's talk about sleep duration and sleep death. And this is a consensus statement that came out from the American Academy of Sleep Medicine and the Sleep Research Society in terms of how many hours of sleep that we all need. And this was based on 15 sleep experts using a modified RAND appropriateness method. And for time's sake, I'm just not going to cover that, and it's actually listed in your slide booklet in terms of what that RAM method was. And it's a way to establish some consensus there. And based on that, the consensus statements goes as follows: that adults should normally get about 7 to 8 hours of sleep per night on a regular basis to promote optimal health. And if one gets less than 7 hours, then there's an increased risk for weight gain, obesity, diabetes, hypertension, heart disease, and stroke. So particularly if you're looking at cardiovascular disorders, anything less than 7 hours might be placing people at a higher risk for this. And this is, again, even though it's a consensus statement, this statement also reflects a little bit in terms of what the literature has indicated so far for us too. And also, getting less than 7 hours of sleep also impairs your immune system function. And so particularly for folks, and I usually use this as an example for my PCCM fellows and sleep fellows as well, because when they get their flu shots, I tell them to make sure that they get enough hours of sleep. And there's good studies that have shown that lack of sleep prior to your vaccination can depress your immune system response to the vaccination. So if you really want to make sure your vaccination is pretty effective, make sure that you do get enough hours of sleep before and after the vaccination shot, because it tends to help with your immune function. And also there's evidence to show that the pain threshold gets altered in patients with decreased amount of sleep, along with impaired performance, motor vehicle accidents, of course, and increased errors, both in terms of, at least in terms of what happens in our job. More than 9 hours of sleep from this task force, based on the consensus statement, states that this may be appropriate, at least for young adults or individuals who are recovering from sleep debt. So if somebody's been sleep deprived for a while, then it makes more sense for them to have more than 9 hours of sleep. But otherwise, if somebody's actually sleeping 9 to 10 hours of sleep on a regular basis, if you exclude all of the factors, then that might be be something that might suggest an increased risk for cardiovascular disease. And this is a complicated slide in the sense that it's not just a cross-sectional shot at how many hours of sleep a patient or a subject is getting. You just might need to keep in mind the society, the social level, and the individual level in terms of determining the reason and why they might be getting the number of hours of sleep that they're getting. Because if you include all of those factors and then they're still getting less amount of sleep, then that puts them at risk for all these cardiovascular risks and then subsequently increased mortality. A good example is something that I'm doing right now in terms of vacationing. Normally I get about 7 to 7.5 hours of sleep. Here, because of issues maybe related to these two factors, I've been eating probably a little bit more junk food than I normally do, and I'm ending up sleeping more than 8 hours right now. So, which may not be a good thing. If one looks at it in a different angle, getting 8 to 9 hours of sleep may be a good thing, but if you put it in context of what related to these factors, that may not be a good thing for me at this stage. So whenever you're asking people in terms of how many hours of sleep that they're getting, though the recommendation is 7 to 8 hours, if it's above or below, you may need to keep that in context with these factors before you attribute risks to cardiovascular disease and thereby subsequent mortality. I hope that makes sense in terms of what I just talked about. This is a slide that again comes from the same position paper that talks about the optimal dose of a sleep model as well as the sleep saturation model. The sleep saturation model is here, which is this orange line out here, basically shows that the odds of incident disease tends to continue to go down as they get more hours of sleep. This is a model that will be applicable for people who are actually having sleep debt and they're trying to recover from it. So that will be this particular model here. While all others, we end up following this U-shaped model where less hours of sleep might be putting us at increased risk for cardiovascular disease, and the optimal duration being between 7 to 8 hours, and anything beyond that, again, in the U-shaped curve, puts us at a higher risk for cardiovascular disease. And in fact, there's data to support this, and this is just one example that I thought I'd show you. This is a study that looked at incident coronary calcification based on both actigraphy as well as subjective sleep report in terms of duration of sleep, and almost follows a U-shaped curve here, where less amount of sleep, the odds for increased coronary calcification was higher, and that tended to drop as one gets enough hours of sleep and starts to go up as the number of hours of sleep actually starts going beyond the 8 to 9 hour mark here. Okay, so now let's look at obstructive sleep apnea. And I think we all know this pretty well. When you have an apneic episode, the apneic episode is associated with hypoxemia. And each of these events that tends to occur during obstructive sleep apnea leads us, because of the pathophysiology, leads to cardiovascular diseases. And one is hypoxemia because of the desaturation that tends to happen with apnea. And the increased sympathetic drive that tends to occur also, along with the arousal that tends to happen following an apneic episode, leads to increased heart rate variability. And also increased effort, the abdominal paradoxical breathing that tends to happen when one has an apneic episode also leads to cardiovascular consequences, and we'll touch upon that here in a second. And the arousal, as we talked about, because of increased sympathetic drive, leads to heart rate variability. And the reoxygenation when we start rebreathing, and the periodic hypoxemia followed by reoxygenation also causes increased radical formations to happen that also increases risk for cardiovascular diseases too. So for time's sake, I'm just going to concentrate on a few of these factors, the hypoxia, not necessarily talk about hypercapnia, which tends to happen if the apneic episode is pretty prolonged. The increased arousals following all these apneic episodes that leads to increased sympathetic drive and heart rate variability, and also the increased intrathoracic pressure. This is an old study, but still pretty relevant in terms of what actually happens when you have an apneic episode followed by hypoxemia. So as you can see here, with each apneic episode that tends to happen, you have hypoxemia. And with these hypoxemic episodes, you see an increase in blood pressure. Of course, if the apneic episode is pretty long, the hypoxemic episode might be a little worse. And when you have significant hypoxemia compared to the hypoxemic episodes out here, the rise in blood pressure tends to be worse, saying that hypoxemia per se, depending on the degree, can make your blood pressure to go up even higher for that particular apneic episode. This might be one of the reasons why in REM sleep, because your apneic episodes tend to be a little longer, followed by significant hypoxemia, you're more likely to see acute rises in blood pressure and acute changes in your heart rate variability in REM sleep compared to non-REM sleep. Also, hypoxemia can put people at risk for cardiac ischemia, and a combination of the previous factors that we talked about, coronary ischemia is very unlikely to happen during this particular state as well. Hypoxia also causes pulmonary vasoconstriction, and as discussed in the past by other speakers, it also leads to pulmonary hypertension. Because of hypoxemia, you can get carotid body stimulation, and that leads to increased sympathetic activity. And increased sympathetic activity in the context of with other factors that's all going on can also increase one's risk for cardiovascular diseases too. This is again another elegant study done by Viren Somers, looking again at a microelectrode that was placed in the peroneal nerve, looking at normal subjects and obstructive sleep apneic patients, and looking at the sympathetic drive, and then looking at the blood pressure at the same time. So these are normal subjects who have normal breathing pattern, and you can see the sympathetic drive at least is not too bad out here, and this is the blood pressure reading. In an obstructive sleep apneic patient, when you have an apneic episode, you can see a significant increase in sympathetic activity, and along with it, you could see the increase in your blood pressure, particularly when there's an arousal following an apneic episode that could potentially, when continued for a period of time, can lead to consequences. And in fact, the previous slide showed something that was happening while one is sleeping, and it doesn't just happen only while sleeping. This translates into even during wakefulness too. So these are normal subjects where when looking at the sympathetic neural activity, you can see in a few of these subjects, the baseline is out here, but in obstructive sleep apneic patients, they tend to be carried over during the daytime, and that's one of the speculations and postulations in terms of increased blood pressure in these patients even while they are awake. What about intrathoracic and cardiac pressure gradients? And we talked about increased effort of breathing against an apneic episode that can cause problems. And this is just to show you an example in terms of what might actually happen. So this is your trachea, heart in a box within the thoracic cavity. This is the pleura. This is your left ventricle, and the normal left ventricle end systolic pressure is usually around 120 millimeters mercury. The chest here is actually the pleural pressure. So when we normally inhale, our pleural pressure is around -5. So the transthoracic pressure gradient, the transmyocardial pressure gradient, the pressure across the left ventricle to the pleura, is 120 minus or -5, and that's 125 millimeters mercury. And that's usually the pressure that's exerted on the aorta, which is a reflection of your afterload, and that's the pressure that's also exerted on your left ventricular free wall. However, when you have an obstructive apneic episode, right during your apneic episode, as we talked about, your effort of breathing increases significantly, right? Because you have an obstructed airway, your pleural pressure now becomes even more negative into the -20, -40, and sometimes even -80 has been recorded. When that happens, your transmyocardial pressure gradient, the pressure difference between your left ventricle and the pleura, which is 120 minus or -80, it becomes 200 millimeters mercury. And that's a reflection, as we talked about, is your afterload. And so, not surprisingly, these patients are at risk for hypertension, but also a sudden increase in your afterload with an increase in your transmyocardial pressure gradient and the stretch that tends to happen here puts this at risk for ischemia. And also because the stretch is in this direction, the atrium also tends to dilate, making people at higher risk for atrial fibrillation too. So another reason why even if one may not be necessarily hypoxemic, if you have an apneic episode that's long enough to cause these intrathoracic pressure swings, then you're more likely to be at higher risk for some of the cardiovascular events that we just talked about. So this is a summary slide in terms of what actually happens during an acute apneic episode. These are some of the intermediary mechanisms in terms of what could be happening that leads to cardiovascular diseases. So there's good biological plausible mechanisms by which how an apneic episode can lead to these issues. And when you have biologic plausibility, then the likelihood is any studies that shows a positive response in that direction might then suggest that there's something that we may need to believe when data starts to come in that direction. And in fact, I'll go about talking about that a little bit here too. And it's also important that as you look at these studies, association doesn't suggest causality, particularly if it's an observation study. And that was something that you would see in most of the studies that have been done related to cardiovascular diseases and obstructive sleep apnea. They've all been mostly observational studies, and that's something to keep in mind. And also, the risk factors for both cardiovascular disease and obstructive sleep apnea are similar. And so the confounding variables tend to be present, and that's something to keep in mind when looking at these studies, such as obesity, more common in male than females, and advancing age. The case control, and we talked about some of the issues related to a lack of randomized controlled trials, but it is what it is, and I think we just have to take it with that face value and look at these studies closely to see what we can make out of it. Also, I think this has been discussed for a while as well. AHI, the apnea-hypopnea index, though this is the best metric that we have currently, is not it's an imperfect metric, and if it's something that you're looking to see if it increases the risk for cardiovascular diseases, may not be the best metric to go by with, but it is what it is. And we talked about issues related to the observational studies. And another point to keep in mind is some of the effects that we see from obstructive sleep apnea and cardiovascular diseases, even though treatment may not be modifiable because some of the end effects might have happened where vascular remodeling tends to happen, and any treatment that tends to correct the stressor, but with ongoing vascular remodeling may not completely revert back to normal. And so those are factors just to keep in mind when you're looking at some of these interventional trials with CPAP as well. So let's start with hypertension here. And this is just a general slide to show that hypertension, systemic hypertension, tends to increase with age, and that's what's listed on your x-axis here. As we all age, the risk for hypertension increases both in men and women. And there are 60 million adult hypertensives in the US, and the majority of these hypertensive folks are actually uncontrolled, and some of them actually still undiagnosed as well. So 25% of the patients with hypertension have obstructive sleep apnea, and good data clearly shows that. And 30% of these hypertensive men had sleep apnea with an AHI of more than 10 per hour. Then this is in comparison to the controls where they had only 9%, where 9% of them had obstructive sleep apnea. 83% of the patients with uncontrolled hypertension, this is where they were using more than 3 antihypertensives, have obstructive sleep apnea. So if you have patients with uncontrolled hypertension, the likelihood of you making a diagnosis of obstructive sleep apnea is going to be higher. The other way around, 40% of obstructive sleep apneics have hypertension as well. So it's almost a bidirectional flow in terms of the prevalence of obstructive sleep apnea and hypertension in each group. And if you look at the Wisconsin Sleep Cohort study, there's a threefold increased risk of incident hypertension over a 4-year period, and this is independent of other risk factors that we had talked about in the previous slide. And if you look at the Sleep Out Health study, the odds ratio is about 1.8 to 2 for hypertension. And as we talked about, there are tons of observational studies that suggest a link between obstructive sleep apnea and hypertension. And at least when you do an acute intervention with CPAP, it does reduce blood pressure, and I'll show you a few slides related to that. Of course, the bigger question is, does the effect of CPAP then translate into diurnal reductions in blood pressure? Because that's exactly what you want to do, or at least you want to see in these patients. And we'll touch upon a few CPAP interventional trials, and then move on to the next cardiovascular event here. Best way to, of course, to look at the data closely is to look at the meta-analysis of all the studies that have been done. And this is just a study that shows all the studies that have looked at the blood pressure reduction with CPAP. And as you can see out here, it crosses the line where CPAP tends to favor a reduction in blood pressure about a couple of millimeters mercury. And just something to keep in mind, even a 2 millimeter mercury reduction in blood pressure has a significant effect on cardiovascular events. And a normal blood pressure pill, an antihypertensive pill, reduces your blood pressure by about 3 to 4 millimeters mercury. So a 2 millimeter mercury difference is still a significant clinical effect from any of these trials on hypertension. And just to look at a couple of these studies here, this is a randomized controlled trial looking at 1 month of CPAP versus subtherapeutic CPAP. And this is the baseline out here. And you can see the dark circled ones are patients who are on CPAP, while the open circle ones are subtherapeutic CPAP patients. And at 1 month after being on therapeutic CPAP, you can see a mean reduction in blood pressure of around 3.3 millimeters mercury in the second graph out here. Also, it makes a difference if one is sleepy or not. And in this particular study, they looked at changes in blood pressure. And here, based on both your sleepiness as well as based on oxygen desaturation. The more likely you're to desaturate, the more likely you see a significant effect on your blood pressure. Similarly, if you're most likely to be sleepy, again, you're more likely to respond to CPAP. And that's something that we've seen in a few other studies. And this is just one of those studies that looked at, from Spain, looked at non-sleepy patients of 723 patients with no cardiovascular disease, and they selected these patients with an apnea-hypopnea index of 20 or higher, with an Epworth Sleepiness Scale of 10 or less. So these were clearly non-sleepy patients. And they were randomized to CPAP versus no intervention with a mean follow-up for about 4 years. The primary outcome was hypertension or cardiovascular event. And basically what they found was no significant reduction was noticed in either of these outcome measures, either of these primary outcome measures. And however, if you look at the post-hoc analysis, more than 4 hours of CPAP use did show an improvement in hypertension and some of the cardiovascular events. So it's possible that this study might have been underpowered, but however, I think another study similarly showed, at least in non-sleepy patients, a reduction in blood pressure and cardiovascular event wasn't as robust as it was in sleepy patients. This is another study looking at a 9-week trial of CPAP in hypertensive in patients with severe obstructive sleep apnea with an AHI of more than 60 per minute, or 60 per hour, I'm sorry, with 2/3 being on antihypertensives. And the control group here was on subtherapeutic CPAP. So they weren't a complete sham group, meaning that these patients were receiving CPAP at a certain pressure, but not in the therapeutic range. And the reason for that is because, as you can see here, I just wanted to highlight, because they were on subtherapeutic, they still ended up having a reduction in your AHI by approximately 50%. There was a significant dropout rate of 47%. And the final conclusion of the study was that there was a BP reduction of around 10 millimeters mercury in the therapeutic CPAP compared to subtherapeutic CPAP. The point to keep in mind out here is this study did show with a reduction in AHI being about 50% in the subtherapeutic group. It also illustrates the point that it's very important to make sure that patients on the right pressure setting to control the sleep disorder breathing events completely. Otherwise, the likelihood of seeing a response may not be there, particularly in these patients with hypertension. What about the role of oxygen? So we just looked at CPAP so far. What about the role of oxygen in hypertension? So this study was done looking at 320 patients with an AHI between 15 and 50 per hour. And they were randomized to 3 different groups: CPAP, supplemental oxygen, and healthy lifestyle. And the primary outcome was a 24-hour mean blood pressure finding. And here, CPAP did decrease the blood pressure compared to the other groups, while supplemental oxygen had no effect on the blood pressure. Interestingly, though, this was followed by another recent study that came out in 2018, this year, looking at supplemental oxygen on the effect on blood pressure effect in patients with obstructive sleep apnea, called the SOX trial. So this was a randomized, double-blind crossover trial, and they looked at patients after they were withdrawn from CPAP. So they had them on CPAP, they withdrew CPAP, placed oxygen, and they crossed over these patients. And the primary outcome was looking at a change in home AM, or morning blood pressure readings. Interestingly, this particular study showed a drop in your systolic blood pressure by about 6 millimeters mercury compared to folks who are on room air. And the mean oxygen FiO2 that was given to these patients were between 2 to 4 liters per minute through nasal cannula. However, interestingly though, if you look at this trial closely, particularly if you look at these measures here, looking at the urine metanephrine, norepinephrine levels, there was no change, indicating that there's, from a biological plausibility, the reason for why there was a reduction in blood pressure with oxygen is not entirely clear. So with the previous study showing no response, and with this study showing a response in blood pressure with use of oxygen, again, one needs to be very careful in assuming that oxygen is a way to go to treat obstructive sleep apnea because you're seeing a reduction in blood pressure. I think we just need more studies in this direction before we say oxygen is something that we could consider. I think you probably have seen studies that looked at Optiflow or high-flow nasal oxygen where there was a reduction in apnea-hypopnea index. Those studies would make a little sense because there it's not just the oxygen alone, but also the pressure from the high flow that might give you a little bit of a CPAP effect that might help with your reduction in your apnea-hypopnea index. And this is not something that would be seen with oxygen at 4 liters per minute, for example. And so I think we just need to be careful in interpreting a study like this to say that this is the way to go for treating our obstructive sleep apneic patients. To summarize what we've talked about from the hypertension point of things with obstructive sleep apnea, untreated OSA is a risk factor for hypertension, and inconsistent effects of CPAP therapy on blood pressure reduction. So you need to make sure that they are on the therapeutic amount of CPAP to be able to see a reduction in blood pressure. Patients who are sleepy are more likely to respond better to CPAP in terms of reduction in blood pressure and thereby cardiovascular events. The same clarity doesn't seem to exist for resistant hypertension, i.e. patients who are on more than 3 antihypertensives, or the data is again sparse in women and minorities, and that's something we need to keep an eye out for. However, if you're wanting to treat hypertension in patients who have obstructive sleep apnea, you may still need to go ahead and treat them with antihypertensives and not completely rely on to wait and see what happens when you start these patients on CPAP. So sometimes you might get a referral from primary care or from cardiovascular, from our cardiology folks to say, my patient is hypertensive, but he's also seems to be an obese gentleman who's got probably sleep disorder breathing, and even if you find out an AHI more than 40 per hour, it's better that you still not only get them on CPAP, but also refer them back to your cardiologist or primary care saying that they still will need to be on some form of antihypertensive measures to help with their blood pressure control. What about heart failure? So the circulating catecholamine levels in these patients are higher, and particularly they tend to be higher as the heart failure severity increases. So as your EF or ejection fraction starts dipping down, the catecholamine levels tend to be higher. And of course, the higher the plasma levels of norepinephrine, the worse the prognosis is as well. And this is one of the reasons, of course, way back in the mid-90s, the rationale for beta blocker therapy for heart failure came into play as well. Interestingly, and this is something you might have noticed in your practice as well, heart failure patients with obstructive sleep apnea tend to be less sleepy than if they didn't have heart failure. And this is something to keep in mind because both from a screening perspective and also from looking for symptoms in these patients, you may not want to necessarily depend on daytime sleepiness as a way to figure out if this is something that you may want to screen these patients for. And of course, the speculation out here is it might be the increased noradrenaline levels or catecholamine levels that might make these patients a little less sleepy compared to those obstructive sleep apnea patients without heart failure. And there is bidirectionality to this, where heart failure may also predispose to obstructive sleep apnea, and obstructive sleep apnea, if left untreated for a period of time, could also lead to heart failure. And the former, where heart failure may predispose to obstructive sleep apnea, is based on a few studies, and this is where they did some experimental manipulation of CVP by applying some constriction to the lower legs, so that by preventing any third spacing and diverting the fluid from extravascular to intravascular, and they found rostral fluid shifts happening, in fact, even leading to increased neck circumference. And doing a pre and post measurement of this, they found increased apnea-hypopnea index as well in these patients. So suggesting that the presence of fluid in the setting of heart failure might increase one's risk for obstructive sleep apnea. In fact, there's biological plausibility to that as well, because when you give these subjects intensive diuretic therapy, you can see a significant reduction in the apnea-hypopnea index pre and post diuresis. And this is looking at the neck circumference, where basically the modified version of neck circumference, looking at the oral airway inside. You can see an improvement of the airway because of a decrease in neck circumference as the diuresis happen. This is just to show you an example of one of our patients in the hospital practice, where we did an overnight oximetry study at the top here. And this is, as you can see, significant oscillated desaturation suggested for significant sleep disorder breathing. And then we diuresed this patient, and 3 days later repeated another oximetry study, and this almost looks normal. So again, the bottom line, or the take-home point out here is, if you see patients with heart failure in the hospital, before you do a sleep study, you may want to make sure that they are well diuresed and in a chronic stable heart failure setting before you want to screen them for obstructive sleep apnea. Some of the trials of CPAP and heart failure, and this is one such trial in 2003, which showed an increase in the ejection fraction by about 9% pre and post CPAP treatment. And this probably goes back to what we talked about in terms of what happens with the intrathoracic pressure swings in a few slides beforehand. So we talked about obstructive sleep apnea causing increased transmyocardial pressure gradient and increase in one's afterload. And if you give CPAP, you're quickly reducing your pleural pressure from -80 to -5 to +5, depending on the amount of CPAP that you end up using. And that will quickly reduce your afterload. And as your afterload decreases and your transmyocardial pressure gradient improves, your ejection fraction might improve as well. So there's possible reasons why, with the use of CPAP in obstructive sleep apnea, you have heart failure, there might be an improvement in your ejection fraction. Also, it's important to notice that heart failure patients who have untreated obstructive sleep apnea, they have a worse survival compared to those who have treated, as shown out here. These are the patients with obstructive sleep apnea with heart failure who were treated, and these were the ones who were untreated. And another good reason to treat these patients with CPAP. What about cardiac arrhythmias? So just go back to the scoring manual. As we talked about earlier, looking at we use only one lead, and the lead ideally should be lead 2, so that way you can look for changes in your sinus beats as well as for any particular arrhythmias. And this is actually a real patient that we had who had a 30-second epoch in a 74-year-old with underlying known cardiac disease with an AICD in place. And this happened during stage N2 and with a heart rate in the 70s. And I think the question is, what type of arrhythmia is this? And in this case, for time's sake, I'm just going to say that this was a wide complex tachycardia. The answer is going to be number 4. And I'll explain why it might be wide complex and not one of the others in a second here. So wide complex tachycardia, again, if you look at the scoring manual, it says that for a rhythm lasting for minimum of 3 consecutive beats at a rate greater than 100 beats per minute, with a QRS duration of greater than or equal to 120 milliseconds. And that clearly fits the criteria for calling it as a wide complex tachycardia in this particular subject, where you definitely have more than 3 consecutive beats, the QRS duration is more than 120 milliseconds, and it's at a rate of more than 100 beats per minute. So in that case, it becomes a wide complex tachycardia. And as we talked about, you need to make the origin of the wide complex tachycardia might then tell you whether it's a VTach or if it's something else. And if for time's sake, again, if the axis is different, so if you have an axis that's completely opposite to the previous QRS complex, then it's probably going to be a ventricular tachycardia. If it's the same complex, if it's in the same direction as the previous QRS complex, then though it could still be a VTach, the likelihood then of this wide complex tachycardia being another abnormal rhythm might increase at that particular stage. So extreme axis deviation with a wide QRS in a single lead EKG, suspect that this could be a VTach. This is just to show you an example of a patient with a VTach. At least luckily this was a non-sustained VTach, but you can see the QRS is in a different axis compared to the wide complex tachycardia out here. So this is, though it's technically would be called as a wide complex tachycardia, among the wide complex tachycardia, this is more likely to be a VTach because of the axis being completely different. Diving reflex is something that you can see with obstructive sleep apnea. Again, what is diving reflex? This is something that you would see with diving mammals, because when they dive and go underwater, they're apneic, and during the apneic episode, for survival reasons, they have an increased sympathetic drive peripherally, so that there's vasoconstriction of the peripheries, diverting blood away from the limbs, so that that blood can go to the heart and the brain. At the same time, you have increased vagal efference to the heart, so that there's bradycardia to preserve the heart, so to say, and divert whatever blood is coming to the heart to the brain, so that it's a preservative mechanism for diving mammals. So this is something that you would see in patients with severe obstructive sleep apnea, where you have increased vagal efference to the heart, causing sinus bradycardia, sometimes even to the point that they might develop a block, and increased sympathetic drive to the peripheries, causing peripheral vasoconstriction. And of course, few things to keep in mind with ST segment depression. Again, be very careful interpreting ST segment depression in patients who seem to exhibit that with a single lead EKG on your PSG. And for time's sake, I may not be able to go through the various differences out here, but if you do see it, please do get a 12 lead EKG. Bigeminy was the previous slide, and of course when you see bigeminis, you want to always think about premature ventricular contraction beats. And interestingly, if you look at the data, even in normal heart, the prevalence for PVCs are surprisingly not uncommon. It's 1% prevalence over a 2-minute and 80% over a 24-hour period. So we all tend to exhibit some form of PVCs on a daily basis. And of course, as we age, as people develop heart disease, then the prevalence for PVCs tend to increase. And there is some prognostic significance to PVCs. It might suggest that, that there could be underlying coronary artery disease as well. And of course, unchecked PVCs, if it continues like the previous slide that showed bigeminis, can cause tachycardia-induced cardiomyopathy. And of course, we don't have good data to show that controlling PVCs actually make a difference. So this is just to show you an example of a second-degree AV block Mobitz type 1 in a patient with sleep disordered breathing. And of course, if you have sleep disordered breathing, you're likely to have a higher amount of PVCs, PACs, and atrial fibrillation. Again, as I'm running out of time, I'm just going to skip through a few slides here This is just a slide to show you that if you were to have obstructive sleep apnea, the odds of having atrial fibrillation is 4 times higher. So that's something. This is a cross-sectional study, and so it's something to keep in mind in patients with obstructive sleep apnea. Similarly, if you have obstructive sleep apnea and it's left untreated, the likelihood of cardioversion to convert AFib back to sinus rhythm, the likelihood of the patient staying in sinus rhythm is going to be lower if you have untreated obstructive sleep apnea compared to if you have treated sleep apnea, and that's basically what this slide shows out here. And again, if you look at the incidence of atrial fibrillation by obstructive sleep apnea status, the incidence for AFib is higher than people without obstructive sleep apnea. So I think the take-home point out here for AFib is obstructive sleep apnea is very common. Obstructive sleep apnea is also an independent risk factor for developing AFib, particularly if you have significant oxygen desaturation. And if you have patients with AFib who are cardioverted and have untreated obstructive sleep apnea, they're more likely to revert back into AFib. And so if you do see patients with obstructive sleep apnea and AFib, it makes sense to treat the sleep disordered breathing in these particular patients. The sudden death, I think in the general population, as you can see, the risk for sudden death, the time occurrence is different. It seems to peak around the midday compared to people with no obstructive sleep apnea. And when you look at obstructive sleep apneics here, you can see that the risk is a lot more in the early morning hours for the reasons we talked about earlier with the REM issues. And also the sudden cardiac death increases as your sleep disordered breathing tends to be worse. The odds ratio is pretty high, or the relative risk is pretty high. Okay, this is Cheyne-Stokes, and with this I'll hopefully close my talk here. This is to show that if a patient with congestive heart failure has Cheyne-Stokes respiration, the survival, it's an indicator of prognosis compared to people who don't have central sleep apnea or Cheyne-Stokes respiration. These are the risk factors for Cheyne-Stokes respiration. So male, PCO2 of less than 38, and the reason for that is because, of course, if you have CHF, your minute ventilation is high, so you tend to blow down your PCO2. Atrial fibrillation, and age more than 60 years. And I think we all know how to go about managing patients with CHFs. There's some studies that show that nocturnal oxygen therapy tends to help. CPAP works in some patients, and in fact, that's what the clinical practice guideline from the American Academy of Sleep Medicine also suggests that you could use CPAP. ASV till recently, and we'll touch upon that here. This is the CANPAP trial, which actually showed overall that CPAP did not do a good job in these patients with Cheyne-Stokes respiration, despite the fact that it seemed to help with oxygenation, helped with your ejection fraction, and helped with both the minimum and the mean oxygen saturation here. And of course, if you look at the post-hoc analysis closely, despite the fact that the overall study did not show an improvement in the primary outcome measure, in the post-hoc analysis for the folks who had their sleep disorder breathing well controlled with CPAP, the survival was better compared to the other groups. So this is actually one of the reasons why the task force that came out with the clinical practice guidelines still suggests that we could use CPAP for treatment of Cheyne-Stokes respiration, and if they fail, then to look at other treatment modalities. And unfortunately, till the SERVE-HF came by, we were using ASV as a way to treat these patients, and as you all know, this ended up showing increased cardiovascular mortality in the ASV arm with an annual mortality rate of around 10% compared to 7.5 in the control group, leading to ResMed issuing a safety notice to the point that none of us are now using ASV as a treatment modality for these patients with Cheyne-Stokes respiration, particularly with an EF of less than 45%. Of course, then what do we do for these patients? We end up going to BiPAP-ST or looking at CPAP or looking at oxygen, though the insurance coverage with oxygen therapy is always a big problem to tackle. And this is looking at a good old study that showed that BiPAP-ST, bilevel positive air pressure with a backup rate, tends to do a better job compared to CPAP or oxygen therapy. And of course, ASV did a lot better job than the other modalities of treatment. There are other options, including using theophylline, acetazolamide, though these are small studies. Carbon dioxide by increasing dead space. Again, though research-wise it looks good, but from a practical purpose, doing that is not easy. And this is just to show you that by increasing dead space, you actually increase your PCO2 levels, and thereby you see a significant decrease in the sleep disorder breathing in these patients. Atrial pacing, cardiac resynchronization therapy can also help to reduce your apnea-hypopnea index or your central apnea-hypopnea index. Heart transplant, though completely doesn't treat it, it does tend to reduce it. And use of benzodiazepines by decreasing arousals might sometimes help a little bit too. This is again showing the effect of resynchronization therapy where the apnea-hypopnea index seems to come down. This is with heart transplant. You can see a reduction in the overall central apnea-hypopnea index, but again, it doesn't completely resolve altogether. And after heart transplant, these patients also gain weight. So you might see a transition from central sleep apnea to obstructive sleep apnea in these patients. So even if they get heart transplant, you may need to follow these patients closely for obstructive sleep apnea because some of the immunosuppressive agents that they use ends up letting them gain in weight as well. So that was a quick rundown. Hopefully you can take off your seatbelt now. And so we covered a few things here, including homeostasis, cardiovascular homeostasis in normal sleep. We talked about the scoring rules, sleep duration and depth, and then the effect of obstructive sleep apnea and various cardiovascular outcome measures, and then Cheyne-Stokes respiration as well. Again, thank you for staying around and really appreciate you being here. Thank you very much. You have time.
Any questions for Dr. Kramer? No? I have a question. Can I?
Sure, please.
Okay. One of the things is how you give such a great lecture. Thank you very much. One of the questions that I have is that pulmonary hypertension and preventive way, what about Viagra?
Sure, thank you. And I didn't have a chance to cover pulmonary hypertension for the reasons that we just talked about. This whole topic is a big topic to cover in 1 hour. So pulmonary hypertension, of course, it's again a little bit of a bidirectional flow too. So if you have pulmonary hypertension and obstructive sleep apnea, you do need to for sure treat the obstructive sleep apnea. Not all these patients with obstructive sleep apnea, when you treat it, does the pulmonary hypertension necessarily get better. However, there might be a small decrease in the mean pulmonary artery pressures in these patients, but you may need to end up using some other treatment modality to help them, and that's where whether you go with any of the prostacyclin analogs or whether you go to PDE inhibitors like sildenafil or Cialis or one of those medications might depend on the reduction that might happen following treatment with obstructive sleep apnea.
I'm always intrigued by the phenotype of sleepiness plus sleep apnea equals cardiac disease, and non-sleepy plus sleep apnea doesn't necessarily equal cardiovascular problems. And I was wondering that there's some very old data that suggests that once you've had obstructive sleep apnea for 10 years or more, that you've remodeled your vascular bed and you're no longer pliable or adaptable to treatment of sleep apnea, reducing that risk. So maybe those patients who are sleepy are fresher sleep apneas, you got more recent onset of sleep apnea. And I was wondering if you had any insight into that relationship, and is it because that they have fewer years for sleep apnea, therefore they sense the difference and they have subjective sleepiness, or is that not related at all?
That's a great question and great comment too, Dr. Chedek. I'm not sure I have a good answer for that. It actually maybe goes back to a little bit of the phenotyping and genotyping that tends to happen too. So why is it that some patients with severe obstructive sleep apnea are not sleepy? And this is, by the way, this is even if you exclude some of the subjective measures out, because self-report is always fraught with some bias too. So even if one way to take that out, why is it that not all obstructive sleep apnea patients are sleepy? Why is it that some are not and some are so? whether this is related to an increased arousal mechanism in some people, because that's where then you go back to looking at the phenotype of these patients. So are the non-sleepy folks have a different threshold for arousals compared to the sleepy ones? And does it mean then their apneic durations are shorter? Does it mean their amount of hypoxemia is less? The amount of intrathoracic pressure swings are different? Those are all open to speculation, so I'm not sure I have a good answer because I don't think we've necessarily dived into the depths of trying to figure out how do these different phenotypes with obstructive sleep disorder breathing pan out in terms of cardiovascular outcomes. But that's definitely something ripe for some further investigation, particularly as we start looking at treatment, where the Harvard group is doing a wonderful job in trying to personalize some of these treatment modalities based on the phenotype of these subjects with obstructive sleep apnea, and maybe we'll find out some more answers here down the road. I know that's not a good answer to your question, but that's a great point, and I think this goes back to looking at the phenotype and precision medicine art, looking at individualized medicine as a way to tease these things out further.